Hello everyone, myself Dr. Shamama. First of all, I would like to thank Oral Health Talks for giving me an opportunity to deliver a lecture on the topic of dental home. We shall sail through the lecture under the following contents: introduction, concept, background, purpose, awareness, policy statement, conclusion, and references. Beginning with the introduction. Oral health is a vital part of overall health. The health care in the first few years of a child's life is very essential to the long-term health of that child. The concept. According to AAPD, a dental home is the ongoing relationship between the dentist and the patient, inclusive of all aspects of oral health care delivered in a safe, culturally sensitive, individualized, comprehensive, continuous, accessible, coordinated, compassionate, and patient and family-centered way, regardless of race, ethnicity, religion, sexual or gender identity, medical status, family structure, or financial circumstances. According to AAPD, the dental home should be established no later than 12 months of age. Let's go through the background. The dental home concept is derived from the American Academy of Pediatrics 1992 policy statement defining the medical home. Let us now go through the need or the purpose of establishing a dental home. High caries rates run in families and are passed from mother to child from generation to generation. The children of mothers with high caries rates are at a higher risk of decay. The modification of the mother's dental flora at the time of the infant's colonization can significantly impact the child's caries rate. Therefore, an oral health risk assessment before 1 year of age affords the opportunity to identify high-risk patients and to provide timely referral and intervention for the child. The American Academy of Pediatric Dentistry supports the concept of a dental home for all infants, children, adolescents, and persons with special health care needs. The following messages displayed in hospitals and clinics can attract the attention of prospective parents and thereby help in creating awareness. For example, first visit by the first birthday, or do you know you can benefit your child's teeth and oral health by starting preventive dental care even before the childbirth? This is the American Academy of Pediatric Dentistry policy on dental home. The policy statement is as follows. The AAPD encourages parents and other care providers to help every child establish a dental home by 12 months of age as discussed in the previous slide. This is to manage a child's oral health care in a comprehensive, continuously accessible, coordinated, and family-centered way. The AAPD recognizes a dental home should provide comprehensive oral health care, including acute care and preventive services in accordance with AAPD periodicity schedules. Comprehensive assessment for oral diseases and conditions. Individualized preventive dental health program based upon a caries risk assessment. Anticipatory guidance regarding hygiene practices, oral or dental development and growth, speech or language development, non-nutritive habits, diet and nutrition, injury prevention. Plan for acute dental trauma. Information about proper care of the child's teeth and gingiva. This would include the prevention, diagnosis and treatment of disease of the supporting and surrounding tissues and maintenance of health, function and aesthetics of those structures and tissues. Dietary counseling. Effective transition from a pediatric to an adult dental home. Now, let us very briefly throw light on some of the factors that govern dental home. These are the American Academy of Pediatric Dentistry recommendations on infant oral health care. Obtain a thorough medical and dental history covering the prenatal, perinatal, and postnatal periods. Perform a thorough oral examination. Assess the infant's risk of developing oral and dental disease and determine the appropriate interval for periodic re-evaluation based on the assessment. Provide anticipatory guidance for the parent or other caregiver regarding dental and oral development, fluoride status, non-nutritive oral habits, injury prevention, oral hygiene and effects of diet on dentition. Tooth eruption is the primary change that needs to be reviewed using a chronology of tooth development and eruption, can be seen in the following figure. The clinician can place the child within a range of normal or discuss the implications of delay or acceleration of tooth emergence. Tooth position, spacing and intercuspation emerge throughout the first 3 years of life as concepts that should be reviewed. These will pay off later when decision needs to be made for orthodontic intervention because parents will understand them. Onset of dental caries. Infants acquire mutant streptococci primarily from their mothers. The initial acquisition of these bacteria appears to occur during a well-delineated age range which is called the window of infectivity, estimated to be 19 to 31 months of age. Therefore, infants should receive early intervention before the established window of infectivity and parents should be given appropriate recommendations concerning oral health care for their infants. These are the American Academy of Pediatric Dentistry recommendations on the prevention of ECC, that is early childhood caries. Infants should not be put to sleep with a bottle. Prolonged nocturnal breastfeeding should be avoided after the first primary tooth begins to erupt. Parents should be encouraged to have infants drink from a cup as they approach their first birthday. Infants should be weaned from the bottle at 12 to 14 months of age. Consumption of juice from a bottle should be avoided. When juice is offered, a cup should be used. Oral hygiene measures should be implemented by the time the first primary tooth erupts. These are some of the oral hygiene measures. Help your child brush twice a day with the following amount of toothpaste. At the age of 6 months to 2 years old, only as much as the tip of a fingernail. From 3 to 5 years old, 5 mm or less. 6 to 14 years old, about 1 centimeter. And 15 years of age or older, 1 to 2 centimeter. Recommendations for toothpaste selection. At birth, clean your child's gums with a soft infant toothbrush or cloth and water. Under 2 years child, do not use any fluoride toothpaste unless instructed by a dentist. Children aged 3 to 6 years, as children younger than 6 may swallow some of the toothpaste when brushing, so need parental supervision. Fluoride toothpaste when swallowed regularly and in considerable quantities may cause fluorosis in children. Only a pea-sized amount of fluoride toothpaste should be used, preferably containing 400 to 550 ppm. Flossing. Once any two of your child's teeth touch each other, it's time to start flossing. Flossing helps prevent cavities by removing plaque and food particles caught between the teeth. Children should be able to floss their own teeth by the time they are 9 years old. Here is the food guide pyramid for children from 5 years of age. For younger children, start with smaller and fewer servings and increase up to the guidelines recommended according to the child's own growth and appetite. Fluoride has played a dominant role in caries prevention programs for both children and adults. Fluoride has two known classifications on effects in controlling dental caries: topical and systemic. Here is the American Academy of Pediatric Dentistry recommendations on fluoride supplementation based on age and concentration of fluoride in drinking water. These are some of the measures beyond fluoride. The reasons to seek alternatives to fluorides is that fluoride is highly effective on smooth surface caries. its effect would seem to be more limited on Pitt and Fisher caries. A high fluoride strategy cannot be followed to avoid the potential for adverse effects, example fluorosis, due to overexposure of fluoride. The recent advances in caries prevention include arginine, probiotics and replacement therapy, plant extracts, chlorhexidine. Here is a list of a few non-fluoride remineralizing agents. Non-nutritive habits. Non-nutritive sucking behaviors, example finger or pacifier sucking, are considered normal in infants and young children. Because persistent non-nutritive habits may result in long-term problems, professional evaluation has been recommended for children beyond the age of 3 years. Some of the non-nutritive habits include thumb sucking, mouth breathing, tongue thrusting, nail biting. Application of habit management. Oral habits are associated with dentoalveolar and or skeletal deformation in some patients. Treatment modalities to control habits may include patient or parent counseling, behavior modification techniques, myofunctional therapy, and appliance therapy. Therefore, discussions on non-nutritive habits should be initiated by both physicians and dentists as early as 6 to 12 months of age. The goal is to cease non-nutritive sucking by 2 years of age. Injury prevention. Traumatic dental injury is a consequence of several factors that will accumulate throughout life if not properly treated. Physical activities play an important role in the child's life. The majority of sport-related dental and orofacial injuries affect the upper lip, maxilla, and maxillary incisors, with 50 to 90% of dental injuries involving the maxillary incisors. The use of protective gear such as helmets, mouth and wrist guards, life jackets, and eye protection or personal protective devices is not negotiable and should be used at all times by everyone. This is the AAPD policy on prevention of sports-related orofacial injuries. Dentists to play an active role in educating the public in the use of protective equipments for the prevention of orofacial injuries during sporting and recreational activities. Dentists of all specialities, including pediatric and general dentists, to provide education to parents and patients regarding prevention of orofacial injuries as part of the anticipatory guidance discussed during dental visits. Coaches or administrators of organized sports to consult a dentist with expertise in orofacial injuries prior to initiating practices for a sporting season for recommendations for immediate management of sports-related injuries, example, Aville's teeth. Mandating the use of properly fitted mouth guards and other protective equipments. Caries risk assessment. Risk assessment is an estimation of the likelihood that an event will occur in the future. Caries balance. Some of the pathological factors causing caries include acid-producing bacteria, frequent eating or drinking of fermentable carbohydrates, subnormal salivary flow and function. The protective factors include salivary flow and components, fluoride remineralization with calcium and phosphate, antibacterials, chlorhexidine, xylitol. This is the AAPD Caries Risk Assessment Form for 5 years and younger. Various biological factors like mother or primary caregiver has active caries, parent or caregiver has low socioeconomic status, child having greater than 3 in between meals containing sugar, child put to bed with bottle containing sugar. All these factors fall under the high risk category. Child has special healthcare needs, child is a recent immigrant, fall under the moderate risk category. The various protective factors like children receiving optimally fluoridated drinking water or fluoride supplements, children having teeth brushed twice with fluoridated toothpaste, children receiving topical fluoride from health professional, children having dental home or regular dental care fall under the low risk category. Various clinical findings like children having greater than 1 decade missing filled surfaces, active white spot lesions or enamel defects, elevated mutant streptococci levels as high risk, whereas plaque on teeth is a moderate risk. Now, this is the AAPD caries risk assessment form for 6 years and older. Adolescent oral health care. Adolescents are defined very broadly as youths between the ages of 10 to 18. The American Academy of Pediatric Dentistry recognizes that the adolescent patient has unique needs due to a potentially high caries rate, unique social and psychological needs, eating disorders, pregnancy, potential use of tobacco, alcohol and other drugs, complexity of combined orthodontic and restorative care, example, congenitally missing teeth, and increased aesthetic desire and awareness, increased risk for traumatic injury and periodontal disease, a tendency for poor nutritional habits, dental phobia. Transitioning to adult dental home. Effective transition from a pediatric to an adult dental home, including early recommendations to caregivers and collaboration, communication and coordination between the pediatric and adult oral health care teams to ensure uninterrupted comprehensive care. To conclude, the dental home, like the medical home, holds strong promise to improve the overall care of all children. The dental home concept extends to older children as well as infants and toddlers, but holds greatest promise for impact if focused on the youngest children. These are the references. Thank you for your patient hearing.